أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على سيد المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. السلام عليكم ورحمة الله وبركاته. كيف حالكم يا صبايا؟ اليوم نكمل محاضراتنا للأسبوع 11. اليوم حنطرح another two examples for drugs that need cardiovascular pharmacokinetic modeling and calculations and adjustment for their doses. Okay, this first topic will be about the pharmacokinetic calculations in practice, cardiovascular agents. Okay. So, the objectives of our lecture today will be as following. At the end of this lesson, you should be able to discuss some cardiovascular agents, example digoxin and lidocaine. We will talk today about digoxin and lidocaine that need special dosing considerations. Then we will describe the clinical monitoring parameters of these cardiovascular agents, digoxin and lidocaine, and you should be able to explain the effect of disease state and patient conditions on digoxin and lidocaine dosing, as well as applying dosing determination methods for digoxin and lidocaine. Okay. Now we will start with the sample pharmacokinetic calculations in practice for the cardiovascular agent digoxin. Digoxin is the primary cardiac glycoside in clinical use. Among its uses is the treatment of congestive heart failures. When given as oral or intravenous, the digoxin doses, the serum digoxin concentration time curves follow two-compartmental modeling. So you are talking about two-compartment modeling rather than one-compartmental modeling. Two compartments انتوا أخذتوها صبايا with Dr. Hadil Al-Ataibi. Okay, so we will follow up the same calculations that you have been previously exposed to with Dr. May and Dr. Hadil. In our case now, we will be exposed to the calculations that you have been exposed with Dr. Hadil. So when given orally or intravenously, digoxin, it will follow the two compartmental modeling, pharmacokinetic modeling concerning the concentration time curve, and it will exhibit a long and large distribution phase. It could be ranged from 8 to 12 hours. Longer, large distribution phase. Remember the distribution in the previous topic when we were talking about the aminoglycosides gentamicin. We have been talking about 1 hour administration period and half an hour administration period. We have discussed that the distribution will be achieved after 1 hour of administration rather than 8 to 12 hours period. So digoxin serum concentrations should not be measured until the distribution phase is finished. Distribution between what and what? It's an equilibrium distribution for the drug concentration between plasma or blood concentration versus tissue concentration for that drug. Digoxin serum concentrations after administration of 250 microgram doses. Imagine, Sabaya, we are talking about microgram. It's a potent medication. It can exert its therapeutic activity with a very small quantity of the drug. So 250 micrograms, it is very similar to 0.25 or 1/4 ربع milligram. Okay, can you imagine how much it is? Very small dose. It's a very potent medication. It could be, this is to be given intravenously of digoxin, okay, where you are talking about the solid line with circles. You can see it. This is the concentration time curve. Please صبايا, you should take care about the plots. Its name, for example, our curve, its name is, it is the concentration time curve, for sure plasma concentration time curve after administration of an intravenous digoxin dose, which is 250 microgram. It's a single dose administration. The plasma concentrations, as you can see here, after administration as an intravenous dose, you can see the solid line with the circles. This is the plasma concentration after time, as we have talked in the previous slide. So, as we have mentioned just a few seconds in the previous slides, that the distribution phase for digoxin does last for 8 to 12 hours. Notice here the x-axis, which is the time after single dose administration. It's only single dose, okay? It is up to 100 hours, okay? If we multiply 12 by 5 half-lives or times to achieve the steady state concentration, it will be around 60 hours. Look at this. This is the concentration in the plasma. It is in nanograms per milliliters. This plasma concentration. It's not the dose. The dose is microgram, okay? Therapeutic concentration initially after intravenous dose administration, it is around 10 nanograms per milliliter. Then look at this, it will be reduced into the blood plasma concentrations into, say, 0.5 nanogram per milliliter after, say, 15 hours. Look at this after 60 or 70 hours. 60 hours, it's also 0.4 or 5 nanogram per milliliters. So this is after this plot or this curve, which is the solid line after administration of a single intravenous dose, which is 250 microgram. Now, after oral administration as the tablet with a similar dose, oral tablet, you look at the squares with the dotted line, you can also see that the bioavailability is less. It's a concentration time curve where the concentrations in the plasma achieved after single oral dose of 250 microgram oral tablet digoxin has been administered. But why the x-axis is very long time? Because the distribution phase for digoxin is long and large, okay? Now, the bioavailability of digoxin can range from 70 to nearly 100%. What does this mean? It means that the F value, it could be between 0.7 up to 1. You have been taking this F value with Dr. May or Dr. Hadil, and I remember that Dr. Hadil has asked you about the bioavailability and absolute bioavailability. Depending on the type of oral formulation, the bioavailability could range from 0.7 up to 1. If the drug is administered by intravenous route, the bioavailability will be 100%. Definitely, the F value will be 1. The elixir and tablet formulations are approximately 80 and 70% bioavailable. Look at this. Elixir, liquid dosage form. You remember elixirs? You have been taking it the last semester, previous semester with Dr. Mai, with the course of pharmaceutics. Dosage forms, their stability. The elixir is more, usually the liquids are more bioavailable when administered orally compared with the solid dosage form. The bioavailability when administering digoxin as elixir is 0.8, while when administering digoxin as a tablet it is only 0.7. The estimated elimination half-life of digoxin is relatively long. It takes around 48 hours. Just if you want to achieve the steady state concentration, multiply the 48 hours by 5. For 48 hours, it is 2 days. So 2 days by 5, you will achieve by 5 you will achieve 10 days. So the steady state concentration is usually achieved after 5 half-lives of 5 half-life of elimination. And in the case of digoxin, because of the half-life of elimination is relatively long, it takes around 48 hours, the half-life. But the steady state achievement after 5 half-lives, it will take around 10 days. Okay, Sabaya? Okay. To continue up with the pharmacokinetic characteristics for digoxin, digoxin is roughly 30% protein bounded. So in the previous slide, I have told you that it has a very long time of distribution, which ranges between to achieve the equilibrium between drug concentration in the plasma and the drug concentration in the tissues. It's around 8 to 12 hours. Also, I have told you that bioavailability for digoxin, for sure, when we are talking about bioavailability for other than intravenous route, because if it is administered intravenously, it will be 100% bioavailable. These are all pharmacokinetic parameters for digoxin. When administered other than intravenous route, the bioavailability can range from 70 to 100%. We have talked about two examples. For elixir, it is 0.8 or 80% because it is liquid, while for oral tablets, it is 0.7 bioavailable. And another pharmacokinetic parameter was the half-life of elimination, which is 48 hours. Okay, now to continue up with the remaining pharmacokinetic characteristics for digoxin, it is 30% protein bounded in the plasma, and it has a relatively large volume of distribution, which is nearly 7 liters per kilogram. If you are talking about an adult male that is weighing 70 kilograms, so the volume of distribution will be 7 by 70, which is 490 liters, or roughly nearly talking about 500 liters. It's a relatively large volume of distribution. And if it is a large volume of distribution, when the drug has a large volume of distribution, it will be widely distributed in the adipose tissue. Once it's distributed in the adipose tissue, its removal back again to be available in the systemic circulation, either for therapeutic responses or for the elimination and excretion outside the body, it takes a very long period or very long time. Also, it is 3% protein bounded in the plasma. All of these will affect its therapeutic efficacy. Okay? We are talking about different pharmacokinetic parameters related to the digoxin. We have talked about the distribution time, the half-life of elimination, the bioavailability, the volume of distribution, and its protein binding. Digoxin is primarily eliminated via renal excretion. So the primary route of elimination for digoxin is renal route as unchanged, but it does undergo hepatic metabolism to a small extent. Roughly 15 to 20% of the drug is metabolized. So it's mainly eliminated through the renal route, with a small proportion which ranges between 15 to 20% that is metabolized by the hepatic route. So the relationship between the digoxin clearance and the creatinine clearance, as it is mainly eliminated through the renal route, it's a direct relationship between the digoxin clearance, the unit is milliliters per minute, with creatinine clearance of the kidney or of the renal functionality measured as milliliter per minute. So it's Direct correlation, we have talked about this since 2 weeks, which is the direct proportional relation between the creatinine clearance and the drug clearance outside the body. As you can see that the clearance of digoxin, Cl here, equals 1.303 multiplied by the creatinine clearance plus 40. What is 40? 40 is the non-renal clearance, which could be, for example, in our case, a little bit the liver metabolism, which ranges previously from 15 to 20%. It could be other than the liver metabolism. So the clearance, if the patient has a severe, moderate to severe heart failure, so the non-renal clearance will be reduced. Instead of 40, it will be 20. So look back again. The squares with the dashed line representing a patient with no disease conditions, the non-renal clearance here it is 40, while for a patient with moderate to severe heart failure, the non-renal clearance, which could be liver, hepatic metabolism or other, it has been reduced to 20 because the patient has moderate to severe heart failure. Okay? Now, how to calculate or to determine the appropriate dosing of digoxin? We have a lot of approaches, as you can remember in the last week when we have calculated the appropriate dosing concerning the amino glycosides and the immunosuppressants, cyclosporin and tacrolimus. We have talked about two different approaches to calculate the doses. The first approach, which is initial dosing determination method, pharmacokinetic method, and the second approach depending on what is present on literature. So several methods to initiate digoxin therapy are available. The pharmacokinetic dosing method, as well as the GELF method, which is similar to the pharmacokinetic dosing method, except a target total body store is selected. Please take care about this concept or the scientific expression or pharmacokinetic expression, which is the target total body store. Okay? So we are talking here about target total body store value is to be selected. Okay? So why to talk about the target total body store? It is something, let us say, like a store in the body for the drug concentration. Okay? It is selected based on specific disease states and conditions present for the patient. We are talking about target total body store, a little bit similar to something like a plasma concentration for that drug. Okay? So the first method, the pharmacokinetic dosing method that has been used previously with our previous examples. And the second method is the GLIF method, okay? Which is depending on the, in our case here, in digoxin drug, it's depending on the target total body. So, the initial dosing determination method, we can depend on nomograms, and as you can remember, the nomogram, it is something like ready-made charts, and we have been exposed to this expression since we have been in the pharmaceutical calculations, as you remember. Nomograms for body surface area determination, and others nomograms for drug dosing determination depending on the body weight, okay, and other disease conditions for the patient, maybe the body age or the patient age. So the nomograms that use the dosing concept in the GLF dosing methods are available. we have ready nomograms depending on the GLF dosing method to calculate the appropriate digoxin dose for different patients with different disease states and conditions. But in order to make calculations easier, they make simplifying assumptions. There are certain assumptions to make calculations is easier. The nomograms are for adults only, and separate versions are needed for intravenous injections. So we have nomograms for dosing administration of digoxin. They are only for adults. Okay, we have nomograms for adults for oral digoxin doses, and we have nomograms for adults for intravenous digoxin dosing administrations. We have no nomograms for children. Okay, we must follow the GLF calculations and the pharmacokinetic dosing method calculation approaches. Now look at the monogram. Monogram for digoxin administration, doses of the digoxin, either of oral route of administration or intravenous route of administration. These nomograms are only available for adults, and they are calculated according to GLF dosing method that we have talked about, not the previous week, not week 10. We have mentioned it in week 9. Okay, look at this nomogram. It's a GLF nomogram for oral digoxin tablets. So these are oral digoxin tablets in microgram as an oral tablet in adult. Each word means a lot. It's very significant. كل كلمة لها scientific expression. This is a GLF nomogram. The values in this nomogram are calculated according to GLF method, pharmacokinetic calculations. It's only for oral digoxin tablets. All these values are for the drug concentration of digoxin per single oral tablet. The unit is in microgram. Just 2 or 3 slides previously, the plasma concentration was measured in nanogram. Okay, here we are talking about the microgram drug dose of digoxin, drug oral dose. Okay, in adult patients, it's not for children or infants with heart failure. Sure, we are administering the cardiovascular drug digoxin to treat heart failure problems. To provide total body store. So back again, we have talked about total body store. It's very similar to plasma concentration, but instead of talking about therapeutic plasma concentration, we are here talking about total body store, which is 10 micrograms per kilogram. So we are talking here back again about total body store, okay, of 10 micrograms per kilogram. Okay, look at the mammogram, dear ladies. Now this is the lean body weight. As you remember, just in the last week, the lean body weight, it's excluding the fat tissue. Now this is the corrected creatinine clearance for that patient as milliliter per minute per 70 kilograms per body weight of that patient, okay, as milliliters per minute. If you look at these values, if the patient has 0 milliliters creatinine clearance value, corrected creatinine clearance, so the patient does have renal dysfunctionality, which is severe. But if the patient value, if the corrected creatinine clearance is increased, say 100 milliliters per minute for his total body weight, depending on a 70 kilograms, look at this, per minute. So as you are going downward in the nomogram, the creatinine clearance has been more appropriate, okay, it's more appropriate, the creatinine clearance, and its value is indicating proper renal functionality. Okay, now look at these values on the top of the nomogram. Here is the body weight in kilograms for 50 kilograms, 60 kilograms, 70 kilogram patient, 80 kilogram, and here this value, it is the body weight, but it is in avoirdupois pound. Look at this, 70 kilograms is equivalent to 154 pounds, okay? So this is the creatinine clearance corrected value indicating the renal functionality. The worst renal functionality is on the top and the better renal functionality is at the bottom. Here is the body weight in kilogram value and the equivalent pound values, and here is the number of days before steady state could be achieved. Remember that we have talked that the digoxin does have a long elimination half-life, which is 48 hours or 2 days, and usually steady state is achieved after five elimination half-lives. So 5 by 2 days, it will equal to 10 days. Look at this. The patient with the nearly normal functionality, steady state concentrations could be achieved after 7 days. As the patient is more diseased, kidney dysfunctionality is increased, he has kidney problems, look at this, 22 days to achieve a steady state concentration for that patient. Now let us explain these values. If the patient is with better kidney functionality and with proper days to achieve steady state concentration, which is around 7 days, okay. Now for 70 kilogram patient, the oral tablet dose of digoxin to be administered for the patient is 250 micrograms. I think it's clear. Now, if the patient is smaller body weight, 60 kilogram, still 250 microgram oral dose of digoxin. If the patient is 50 kilogram body weight, also 250 microgram tablet oral digoxin to provide what, Sabaya? To provide 10 microgram per kilogram total body store per day. This is the appropriate therapeutic drug concentration. Now look, if the patient body weight is increased 80 kilograms, 90 kilograms, 100 kilograms, the corresponding oral dose of digoxin will be increased. It will not stay 250 micrograms. It will be 375 microgram per dose for the patient with a body weight of 80 kilograms. It will be 375 microgram for a patient with a body weight 90 kilograms, and it will be 500 micrograms, twice the dose. That is for 70 kilogram patient body weight. It will be 500 microgram oral digoxin dose per tablet for the patient of 100 kilogram body weight. Okay. Now this is the case, let us say, for a patient with appropriate kidney functionality with a steady state achieved after 7 days. Now let us take a worst case, or a case which is with bad kidney or renal functionality. Let us talk about this value, which is 40 milliliter per minute corrected creatinine clearance, which is indicating a bad renal functionality. Okay. Now look at the 70 kilogram patient here. For the 70 kilogram, for the 40 milliliter per minute creatinine clearance, and patient with 70 body weight, which is similar to 70 kilograms body weight, which is similar to 145 pound kilogram. Look at the dose. It will be 187.5 microgram oral digoxin tablet instead of 250 microgram oral digoxin tablet. All of these to achieve what? 10 microgram per kilogram total body store. But the steady state in this case for that patient with a 40 milliliter per minute creatinine clearance with bad kidney functionality, look at the steady state concentration. It will be achieved after 13 days instead of 7 days. Just dear students, if you go back to the previous slide for the 70 kilograms to compare when we have zero creatinine clearance, the 70 kilogram body weight, the dose will be reduced further to 125 microgram oral digoxin dose per day with a 22 days to achieve a steady state concentration. Now, all what have been previously talking about, we have talked about the oral digoxin dosing. Now we are talking about the intravenous digoxin dosing. The intravenous dose also in microgram in other patient, and this is gelfnomogram with heart failure. طبعا for sure we are administering the digoxin to treat the heart failure problems, to provide back again total body store of 100 micrograms per kilograms. Okay. Now if we want to compare, definitely dear students, definitely dear students, when you are talking about intravenous dose, so the doses compared with the digoxin, oral digoxin will be a little bit smaller. Now back again, here is the corrected creatinine clearance with the similar smaller value is at the top, and the larger values is at the bottom. The larger values for corrected creatinine clearance indicating proper kidney functionality, proper renal functionality, proper renal clearance, and we have mentioned that the digoxin is mainly eliminated through the renal route. So look at this. For 70 kilogram patient body weight, the appropriate dose, intravenous dose, it's back again 250, but for 60 kilograms it's 200. When it was an oral dose, it was still 250. You can go back to the previous slide. And for a 50 kilograms patient body weight, okay, it is 175 microgram compared with oral, which is 250 also. Look at this, 90 kilograms body weight, it is 300 microgram compared with 375 microgram for oral. For 100 kilogram body weight patient, it is 350 microgram intravenous dose compared with 500 microgram oral digoxin dose. What about numbers of days to achieve steady state? It's similar number of days, starting with 7 days for patients with relatively appropriate renal functionality to 22 days for patients with kidney dysfunctionality. Now look back again about the values when the patient has zero milliliter per minute, the corrected creatinine clearance indicating improper kidney functionality. The dose has been reduced from 200 for body weight. For a patient with body weight 70 kilograms, it has been reduced from 250 micrograms into 125 micrograms, from 250 microgram intravenous dose into 100 only microgram intravenous dose to produce a total body store of 100 microgram per kilogram. Now let us take this example, which is an MG. It's a clinical case. He is 50. He is 50 years old, 70 kilograms. His height is 5 feet 10 inches. He is a male with atrial fibrillation for less than 24 hours. So there is a need for digoxin administration. It's a cardiovascular problem. His current serum creatinine, okay, is 0.9 milligram per deciliter. There is a need to calculate the corrected creatinine clearance. This is serum creatinine value, serum. We want to calculate the creatinine clearance through the renal route to be able to determine the appropriate dose from the nomogram, GLF nomogram for an adult. He is an adult, he is 50 years old, or depending on our pharmacokinetic modeling calculations. And it has been stable over the last 5 days. Last 5 days since admission. Compute the intravenous digoxin dose. We can calculate it either depending on the GLF nomogram for the adult. For this patient, the desired steady state average, the required desired steady state is 1.2 microgram per liter, or depending on the pharmacokinetic modeling. Let us see how we will. In the question, it hasn't been mentioned that the patient has any kidney dysfunctionality. But it has been mentioned that the patient has 70 kilogram body weight, okay, So assuming that the corrected creatinine clearance is 100 milliliter per minute, and look at this, it is the nomogram for IV digoxin. Okay, his body weight, the body weight is 70 kilograms, so the appropriate dose it will be, and he has mentioned that it has been stable, the serum creatinine, over the last 5 days. The dose will be around 250 microgram intravenous dose. Now let us try to calculate the. Now we should first of all estimate the creatinine clearance. The value that we have it has been given to us in the question is the value of the serum creatinine, which is 0.9 milligram per deciliter. So this patient has stable serum creatinine over 5 days, and he is not obese. Okay. So the Cockcroft-Gault equation can be used to estimate the creatinine clearance. Depending on the Cockcroft-Gault equation, the creatinine clearance will equal 140 minus the age, which is 50 years, multiplied by body weight, which is 70, divided by 72, multiplied by the serum creatinine value, which has been given in the question, which is 0.9 milligram per deciliter. So the creatinine clearance will be 97 milliliters per minute. Okay. Take into consideration that the deciliter is 100 milliliters. Okay. Okay, just as has been mentioned in the previous screen that or slide, that if the patient is he is 70 kilograms body weight, and they have mentioned no any problems with his kidney functionality, the appropriate dose intravenously, look at this, will be 250 micrograms intravenous dose per day. To continue with our example, so you can either use the appropriate approach to calculate the dose from the nomogram, but remember that the value that has been given to us in the question is the serum creatinine. You should be able to calculate the corrected creatinine clearance by using Cockcroft-Gault equation because he is not obese. You can use average steady-state concentration equations to compute the digoxin maintenance dose. It needs calculations of drug clearance. You will see now that we will end up with the same result, which is 250 microgram per day. Let us try the calculations now. First of all, you should be able to calculate the corrected creatinine clearance, which equal 1.303 multiplied by the creatinine clearance that has been just previously collected, plus the non-renal creatinine clearance. Here the non-renal creatinine clearance is 40 milliliters per minute, and we have just calculated in the previous two slides the creatinine clearance from the serum creatinine to be 97 milliliters per minute. So the clearance will be the total creatinine clearance will be corrected creatinine clearance or drug drug clearance. Here is we are calculating digoxin clearance from the corrected creatinine clearance, which has been previously calculated as 97 milliliters per minute. So the drug clearance value will be 167 milliliters per minute. Okay. So in slide 14, just before 3 slides, we have been able to calculate the creatinine clearance by Cockcroft-Gault equations since the patient is not obese, and it was being calculated, it had been calculated as 97 milliliters per minute. Okay. Next, after calculating the drug clearance, okay, this is 97 creatinine clearance. Okay, now the 167 milliliter per minute, take care of units Sabaya, is the drug or digoxin clearance. Then we will calculate using the equation of the average steady state concentration, which has been mentioned in the question, as the desired steady state concentration is to be 1.2 microgram. Here it is 1.2 microgram per liter. So the maintenance dose by tau will equal steady state concentration multiplied by the drug clearance. This is not the creatinine clearance here. Divided by F. So convert the 167 milliliters per minute into liters per day. Why liters per day? Because the steady state concentration, its value is in 1.2 micrograms per liter. So we should convert the 167 instead per minute per day, and we will change the milliliters into liter per day instead of milliliters per minute. So 167 milliliter divided by 1000, it will be converted into liter, and the 1 minute to convert into day, it should be divided by 60 minutes per hour by 24 hours per day. So we have converted the 167 milliliter per minute clearance value of digoxin into 240. It's equivalent to 230 liters per day for digoxin. Okay. Then the maintenance dose by tau will equal steady state concentration is 1.2 microgram per liter. Okay, multiplied by the clearance 240 liters per day divided by an F value which equal 1. Remember that it is an intravenous dose, so the F will be 100% bioavailability. This will equal to 288 micrograms per day, which could be rounded to 250 micrograms per day, the maintenance dose. Let us switch to another example cardiovascular drug, which is lidocaine. So concerning lidocaine as an introduction, it's a local anesthetic agent that has also antiarrhythmic effect. When given intravenously, the serum lidocaine concentration time curve follow the two compartmental modeling similar to digoxin. The distribution phase in our case lasts for 30 to 40 minutes is observed after administration, while you can remember that the distribution phase for digoxin was around 8 to 12 hours. Okay, lidocaine half-life of elimination ranges from 1 to 1.5 hours in normal adults, while that for digoxin was around 48 hours or 2 days due to the large volume of distribution for digoxin. For lidocaine, it could be up to 5 hours or more in adult patients with liver failure or liver problem. Lidocaine serum concentration initially drop rapidly after an intravenous bolus. Look at that, we are talking about intravenous bolus, as drug distributes from the blood into the tissues during the distribution phase. The distribution phase, just as we have mentioned, it is around 30 to 40 minutes only, 30 to 40 minutes compared with 8 to 12 hours for digoxin. So you can notice here the concentrations as microgram per milliliters. Also, if you compare with the digoxin, the appropriate plasma concentrations were in nanogram per milliliter versus time here it is up to 6 hours, while the time with digoxin was up to 80 hours, as you can remember just previous few slides in our lecture. Okay, even 100 hours in the case of digoxin. So what are the basic clinical pharmacokinetic parameters concerning the lidocaine? It's almost completely eliminated by hepatic metabolism into two metabolites. Almost completely eliminated by hepatic route, while for digoxin it was entirely eliminated through the renal route. It is metabolized into two metabolites more than 95%. The hepatic metabolism is mainly via the CYP3A enzyme system. Because both metabolites are eliminated by the kidney, so patients with renal failure should be monitored for adverse effects due to the metabolite accumulation. The metabolites are further eliminated or excreted through the renal route. Even though lidocaine serum concentrations are within the therapeutic range, but we should monitor the patients with renal failure because the metabolites accumulation will result in severe adverse. Now, the hepatic extraction ratio for lidocaine is relatively high. It's around 70%. So lidocaine is typically classified as high extraction ratio drug. Okay, plasma protein binding in normal individuals is around 70%, which is relatively high value compared with that of digoxin, which was around 3%. Several methods to initiate lidocaine therapy are available to calculate the initial dose and determine it. The pharmacokinetic dosing method is the most flexible technique, and the literature-based recommended dosing is a very commonly used method to prescribe initial doses for lidocaine. Literature-based, it's usually available to compare with what has been published in literature about the dose for our patients. Examples of dosing will be discussed in a more comprehensive manner in the tutorial session that will be with Mrs. Naifa the day after tomorrow. Best wishes for all of you, dear students. Hope you the best times are coming to you. And thank you a lot for your time. I'll open discussion board. It will be available for you at any time. Just send me ask me any question, me or Mrs. Naifa, and we'll reply to your questions. The discussion board will be open from today to the end of Thursday. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh.